All right, well, let's talk about Joint Commission, then we've got a few other things we're going to talk about too, including our panel. One thing I want to mention to you as well, Neil and I are switching in the morning. He has a commitment with a conference call. I'm going to go at 8 a.m., I believe with propofol. And so if you just note your schedules, we're going to switch those if that's not too upsetting to anyone. All right. Anyone had a Joint Commission survey lately? Anybody love that process? You know, very interesting process, and things have changed a little bit. Actually, August 2006, they entered this revision process to really make things different and better, and they're feeling some pressure because some other agencies are out there that are also going to be able to accredit hospitals, and so they have to be more customer friendly. And one of the moves they made, this is amazing to me, as of 2008, they really changed their name. It's not JCHO anymore. They said they just want to be known as the Joint. And that is making everything painfully clear now, because we always wondered what they were freaking smoking with all these. But seriously, call them the Joint. That's what they want to be called. So now they're cool or something, right? All right, so what is their goal? What are they trying to do? They're just trying to standardize processes to improve patient care delivered to the public. Now that sounds like a great thing to do. That's mom, that's apple pie. Why should we argue with that? We shouldn't, but the devil is in the details. And that was the problem in the past. If anyone's gone through a survey probably in the last 5 or 10 years, you know that some of the processes they used and some of the standards that they use and measures don't really apply very well and haven't really reflected what quality is provided in the hospital in general and in the emergency department. And so they've lost credibility that way. So fortunately, they were going through this revision process, and I'm really hopeful that they're going to focus more on what we think is quality and really make things better. All right. Are there any alternatives to accreditation? Well, there actually are. Is anyone accredited, your hospital you're working at, accredited by someone else other than the Joint? The Joint. Nope. Well, you've got some options out there. Yours?
Well, in New York State, the state health department is responsible for accrediting hospitals. They proxy to the Joint.
Okay.
So in the absence of the Joint Commission, the state health department will be responsible.
Well, I think the state health department has to approve its function in your state, and that may be set up in your state legislature, but the only body who can accredit another agency to actually approve hospitals is CMS. And CMS has actually approved 2 other agencies. The new kid on the block is DNV. DNV Healthcare. It's a Norway-based company. Now they're in Houston, so they're a little closer to us now. And they're out there. And they've actually accredited, let me get the exact number here for you. It's 27 hospitals in 22 states, so they're not real big yet. But they have noticed a niche in the market because nobody's happy with Joint Commission and they're paying a lot of money to the Joint. So they want to make sure that they get in the market early. And what they're doing, they've kind of added the requirements that CMS has for participation as well as the ISO 9001 system. And what ISO is, basically an international organization, has I think 157 nations involved with this, and they don't specify just for standards in healthcare. It's all businesses, and they look at standardization. So they've included these processes in their accreditation process, which may or may not be a good thing. We'll have to see how it plays out. But CMS has accredited them, has approved them to say you can go ahead and accredit hospitals if you want. And so a hospital could say, fine, I'm going to have them do it and not have the Joint do it. Another alternative, kind of interesting, is the Healthcare Facilities Accreditation Program from the American Osteopathic Association. Now, they've been accrediting hospitals since 1945, usually just osteopathic hospitals. Now, they're also interested in doing more because they're not accredited or approved just to accredit osteopathic hospitals. They can do any hospital. The issue with them is they're more focused on policies. They're policy-driven, as opposed to the Joint and DNV are more on outcomes. And that's what we really want, are outcomes. If you want an easier accreditation process, well, go with the AOA then, because if you've got the policies in your book, well, it looks like a pretty quick survey for you and you'll be done. It's a little easier process. The tough thing with American Osteopathic Association is they only have 125 hospitals that have used them, and only 45 solely rely on them. That means those 45 are also, have decided not to use the Joint Commission or somebody else, but the rest of them are doing dual accreditation. So what that means is the American Osteopathic Association has likely said, I don't know this for a fact, but I believe it probably is the case, said if you're going to be an osteopathic hospital, you have to use us. And if you also want to go ahead and get accredited by the Joint or whoever else, you go ahead and do that. But I think that's why you have hospitals that have joint accreditation there. All right, so what's new with the joint, besides the name? And do you guys like the name? Is it feeling better to you? Less words, sounds cool? I like it. So the joint. And I don't know, I want to go see where they're at, because maybe they have a new building and they've painted it and they've got like cool stuff on it. And you're like, that's the joint, that's where we work. I think it'd be cool. All right, does anyone know where it's located? I don't even know where they're at. Any ideas? Where is it? Illinois. I think you are right now that you said he thought it was in Illinois. So take a road trip, we'll visit the joint. That'd be cool. All right. So what's new? A lot of this is housekeeping, but some of it really isn't. The housekeeping changes, they're resequencing the standards and elements of performance. Remember, the standard is, this is the standard we expect you to perform to. And here are the elements of performance that lead to that standard. And they base their decision on accreditation of whether you've hit those elements of performance or not, therefore fulfilling the standard that they're looking at. And so those are being resequenced and they're being rewritten. Language clarification, they had redundant standards and elements of performance that were in some standards and also found in other standards, so those have been consolidated. So basically, a lot of housekeeping. And they've also really revised their scoring system as well. They are moving away from the numbered scoring system that they have. They're still going to use a scoring system, but it's not going to be a point system that they've used previously. Now, what they're going to use is a concept called criticality. And you know, I'm loving the new joint because they just invented a new word. That is not a word, is it? Criticality? Well, it is to them. They define it right in their new manual. It's immediacy of impact from noncompliance on patient safety and quality of care. So that's criticality. So if somebody comes up to you and says, I have an issue with your criticality, that's what they're talking about. But I really do not think that is a true word. So maybe it'll make it to Webster's at some point. But they are just charting their own path here. All right, what they used to say is, if you had insufficient compliance with a particular element or standard, it was a 0. You just got a 0. If it was partial compliance, you got a 1. If you completely met the standard, it was a 2. And if you had one or more elements that was a 0 or 35% or more that were a 1, well, then you were not in compliance with that particular standard. And this was based on points. It was kind of interesting. If you were 1.5 to 3 standard deviations away from the accepted mean of those who did not have complete compliance in all those elements, well, then you would have a conditional accreditation. And if you were beyond the 3 standard deviations, you would have a denial of accreditation. So it was really a point system which didn't work very well. What they've gone to now is maybe a little more interesting, and they've gone to a 4-level classification system. If they come to your hospital and they survey you, look at your policies, look at your procedures, and they find an immediate threat to life. That means, for instance, the examples they give are inoperable fire alarms, high rate of infection, something that's going to impact patient care right now. Well, they're going to deny your accreditation. You're going to remove it. They're going to remove it on the spot, usually. And what they're going to expect you to do is provide them, the hospital has to provide them with a plan for fixing this. Once you provide the plan for fixing it, they'll give you a conditional accreditation at that point. And they're going to come back and they're going to survey you. And then you can have that conditional component of the accreditation removed, so it's ugly. But that may make a lot of sense, though. If you don't have fire alarms, if bad things are happening potentially to the patients at the hospital, should you really be accredited? You probably should not be. The second level are situational decision rules. Those are if your hospital is unlicensed or you have unlicensed providers on the medical staff. They say those are pretty bad, so they'll give you either a preliminary denial or a conditional accreditation based on whatever the accreditation committee decides to do with your specific circumstances. So a lot of judgment there. The third category is immediate impact requirements, and these are based on implementation-based requirements. So if you don't have any way to assess pain at your hospital, or you don't have a plan for moderate sedation and how that's done, well, then they are very worried about the immediacy of criticality there, and they're going to potentially pull your accreditation, but they're going to say, with all non-compliant elements of performance, you have to send in to us within 45 days a form that says that you have remedied this and you have substantial compliance, and that's their new process in place, 45 days. The fourth category is less immediate impact requirements. And this is, for instance, if you don't have a very good infection control plan. Nothing's going to happen right away, but they want it fixed. Same process there, but they'll give you 60 days to file this form and give them evidence of substantial compliance. All right, if you look at page 119, that's right there in your book. I am not going to go over this. If I want to clear this room in under 5 seconds, I'm going to start going down table 7. This is there, so if you're going to have a survey coming up in the next year, this is likely how they're going to score things and how they're going to decide if they're going to credit your institution or not. And so I need you to look at that only if you want to. I'm not going to spend your time here doing it. All right, what about the unscheduled visits? Unscheduled surveys, do you guys like those? It's cool. Hey, visitors, we didn't expect anyone. They show up at your hospital, show a badge, and say, get me your administrator on call. We're here to do the survey. Not a pretty picture, but that makes certain then, hopefully, that the hospitals aren't just preparing for the survey date, but they're making sure the standards are up to snuff every day. You know how we used to do it. You know the survey's coming up in about a month, so, all right, no more eating at the desk. All right, where's the Hemocult developer? Give it back. You can't use it anymore. I mean, I can't be the only one who experienced this, right? The hospital would crack down on this stuff for about a month before, and then when the survey was over and they got their accreditation, you could do anything you wanted to. You could eat and you could drink the Hemocult developer if you wanted to. It didn't matter at that point. All right, so they're going to do the unannounced surveys. The only time that there's an exemption for that is if you're a brand new organization, or it's your first survey, or you've had denied accreditation in the last 2 years, or you just decided you don't want to participate with this process in the last 2 years, they'll schedule your survey. But they don't have to either. They said they probably will if you look at their documentation. So you'll feel pretty comfortable that they're probably going to schedule it with you, but if they don't, they can still show up. And also there are blackout dates. This is important as well. Every hospital, every healthcare entity has the right to say, you know what, we're going on vacation in March. We don't want you to come during those dates. They will do, quote unquote, all that they can to comply with those requests. But everyone has the right to put some blackout dates so that we don't want someone in our hospital. So you can let your hair down during the blackout dates. All right, let's talk about core measures. Everyone love core measures? In contrast to accountability measures, which is PQRI, Physician Quality Reporting Initiative, core measures are what the hospital is based on. Still, it's voluntary reporting. But how does that look for a hospital if they say, you know what, we don't like the process, and it's voluntary, so we just won't provide any data? That's like saying, you know what, I'm guilty of violating every potential core measure because I refuse to supply the data. So everyone supplies it. And the core measures, we love them. Do they work great? Not all of them, exactly. And hopefully they will improve as emergency medicine has more of a presence in these discussions and these decisions about what quality measures are selected for our specialty. And I agree with you, they're not great, but hopefully they're getting a little bit better. What I did was summarize what some of the changes are that will affect us. There are pages and pages of changes that they've done with these things, but here's what impacts us the most. And is anyone here doing chart review or helping with the process of core measure assessment at your hospital? Okay, well, I'm mostly talking to you guys then too. There are a couple loopholes here they've added for us which are really helpful. If you know you gave an antibiotic in the ED for pneumonia, but you just don't know what antibiotic it is, they're telling you just select antibiotic NOS, and you can go back and tell your quality manager if you select that, it's there somewhere, you'll get credit for it, it's okay. It doesn't have to be a specific antibiotic, but what other people have done is so we can't find it, so we're not going to claim it. Remember, it's self-reporting too, so you have some latitude. And also the 24-hour rule. If you've had antibiotics, if the patient's had antibiotics 24 hours prior to the ED visit, prior to arriving at the hospital, they have extended that now to 24 hours or the day prior. So there's more of a liberal approach to interpretation here. And one thing I'll tell you as well, that's been confusing to a lot of people. What does that mean? So the patient had antibiotics 24 hours prior to hospital arrival. So do you have to give them antibiotics in the ED? No, technically you don't, per the core measure. Is it the right thing to do if somebody comes in with a failed pneumonia on oral antibiotics? Yeah, we're going to do it. What that does, though, if you do not give the antibiotic in the ED, you do not have to do the blood cultures. If you decide to give the IV antibiotic in the ED, well, then you have to comply with the blood culture core measure as well. Everybody love the core measure for blood cultures? A lot of data to support that, huh? A question here.
Yeah, the blood culture for core measure for the CMS, it's only if they're being in the ICU is a requirement. It's not, you just have to have, if they do blood culture before antibiotic, if you don't do blood culture, you're not going to be in, you don't have to do blood culture. For a joint commission, you have to get cultures regardless, even if they're not going to be in.
They are. They've relaxed that a little bit. I'll tell you what they've said here is, and this is going to help us, this is one of those loopholes they've added for us. If in the medical record you just can't tell whether it was given within 24 hours or not, you don't know if the blood culture was obtained, All you have to do is select value 2. We don't know if the blood culture was obtained or not, and what it does at that point is exempts it from the pneumonia 3B core measure, which is the one that requires us to do an ED blood culture before administering antibiotics. And then it defaults to, I think it's 3A, the ICU antibiotic requirement within 24 hours.
But if you say, if you're talking to your admitting attending and saying, look, I'm not going to give blood cultures as community-acquired pneumonia, they're not required, they're not useful, et cetera, for CMS, you're off the hook, they're not going to be used. For a joint commission, are you still going to get gigged then?
For the core measures, I believe it's still a requirement on all of those community-acquired pneumonias. It's interesting, too, you should look at their definition of community-acquired pneumonias. That includes patients coming from community extended care facilities. Now, to us, clinically, those are nosocomial pneumonias. So it's kind of a flawed process, and I certainly wouldn't be the one to stand here and defend these, but what I want to do is make sure you're aware of what they've changed and some of the things I've learned along the way that kind of help us interpret these and how to use them. You know, blood cultures, for instance, they don't say how many you have to get. They don't say how much blood has to be in a blood culture tube. Hey, get a drop. Get a drop and stick it in a blood culture tube and send it away. I mean, I order 1, I don't order 2. I think it's a wasted test to begin with. If we have to comply and they're going to be upset with us if we don't, order 1. Yeah, Peter, you had a question or a comment?
One great way of increasing your compliance with these pneumonia protocols, for those of you that don't know, if it's an atypical or unusual presentation, then it doesn't count. So any pneumonia that, for instance, you were working up belly pain and you found a pneumonia on CAT scan or something like that, if your admitting diagnosis is atypical pneumonia with atypical presentation, then that doesn't go in the database to begin with. So if you're not at the 4-hour mark or whatever else, it really doesn't matter.
Yeah, Peter's right. And what you can do, as we've tracked this, I mean, we have really done a lot with core measures with our group. And we actually used to have it as a component in our incentive-based compensation program. So our docs were very interested in this. But what we did, which complies with Joint Commission and CMS, is if you have identified a late discovery of pneumonia, at the time it's entered into the differential, technically is the time when your timing should start. But you have to specifically state that in your record. You can't assume that's the case. So 2 good examples, like Peter mentioned, you're working up abdominal pain, you get a CT of the abdomen, the radiologist says, hey, there's a right lower lobe opacity, we think it's consistent with pneumonia. Or you're doing a PE workup, and then you realize, oh, it's not a PE. 4, 5, 6, 8 hours later, you realize, wow, it's a pneumonia, I'm going to start antibiotics. If you document it was not in the differential whatsoever, then if your chart abstractor understands that concept and they're looking for that, then that can be exempted. It absolutely can be. The tough thing is when these things are identified from triage and not having any process to get the ball rolling with these patients. One thing that's helpful too, you know, if you're going to use multiple antibiotics, you can give a dose of Zithromax or something PO, doxy or Zithromax at triage, and give the parenteral antibiotic if you want to when they come in the back. Again, it does not have to be parenteral. It has to be that first dose of antibiotics, so if you get the first dose on board, I mean, maybe it's a little bit of gaming, but I tell you, if you look at some of the data, we're getting a little off track here, a little data on some of these antibiotics and whether you actually need to give them parenterally or not, a lot of times you don't need to give 2 parenteral agents anyway. Community-acquired pneumonia that's uncomplicated without prior lung disease, you don't necessarily need to do that. So there are ways to make it easier for you. All right, so enough said with pneumonia, and I do know it's been said that the blood culture core measure is going away. And CMS and the Joint have also noted that it really doesn't have any evidence to support it. I am amazed that it is still there for this upcoming year. I do not know why someone wants that in there so badly and we can't get it removed. But it's coming, so don't worry. At some point, we'll get rid of this. All right, time of antibiotic administration. There's an article published in JAMA, I think as far back as 2000, Actually, I think it was 2007, if I'm thinking correctly. And it was stated there, actually, I think it was from CMS, I believe. CMS or the Joint, one or the other, and said, listen, this time frame of antibiotics is really ridiculous, and 4 hours is certainly ridiculous. We can relax this. And so a lot of people have gone to 6 hours. And now, finally, the Joint has said, I think the article was written by someone from CMS, because the Joint now has said, yeah, let's just go ahead and relax it to 6 hours. Not that there's great data to support that either, but let's make it easier for us. The key is, should we get antibiotics on board in a reasonable time frame? Absolutely. Particularly sepsis is a better argument. Pneumonias are great data to support it. I don't know that there is. All right, how about MI? Anything changing there? Well, PCI, they used to give you a 120-minute time window to get door to needle. And I think, honestly, with the data that I've read on this, the reason was they really couldn't get anyone to comply with this measure at first, so they had to make it reasonable. Now they've matched what the standard of care is, and they've gone to 90 minutes. And beta blockers. Beta blockers, interesting. When I wrote this chapter, they hadn't changed it. As of December 31st, they have retired the beta blocker core measure. You guys happy with that one? You know what I don't like about this concept is that this whole core measure issue and has really resulted in a black eye for beta blockers. You know, I tell you what, I love beta blockers. I think beta blockers are a great drug for MI, but you have to apply it to the right people. You really do. What I loved about the measure, too, is our docs would go crazy. What if they get hypotensive? What dose should I give? Again, they never specified if it needed to be a PO dose, what dose it needed to be, what agent it needed to be. You could give a beta blocker and comply very easily. The whole issue around this and removing it and retiring it as a core measure is the COMMIT trial. And the COMMIT trial done in China, they said, wait a minute, there is a 30% increased risk of developing cardiogenic shock with beta blocker use. And I'm sure you've probably heard that from your cardiologist also. You know, particularly an inferior wall MI, let's not use it. It's dangerous. Well, if you really dissect that trial, what did they do? They included patients with existing heart failure and a lot of patients above age 70. What they don't tell you in a lot of the circles of discussion are that they also decrease primary VFib and reinfarct by 15%. So what the article's telling us is not that beta blockers are bad. We've had some bad and misinterpretation of that data. Beta blockers are really good in the right patients. We have to be careful. In 70 years of age and above, and those who already have existing heart failure, then you're asking for an episode of cardiogenic shock. And would anyone consider giving beta blockers, particularly parenteral beta blockers, in somebody who already has heart failure in front of you? No. So it's interesting that those patients were even included in that study. So be a little careful. Don't throw out beta blockers entirely because everyone's jumped on the bandwagon with this thing. Beta blockers still do reduce myocardial oxygen demands and are good in the right patients. So be a little careful with that. All right, patient safety goals. Are you ready for the patient safety goals? We've got just enough time to go through this. And CMS as well as the Joint are really focused on this. What I've done is, there are a bunch of them. I distilled them down to the ones I think will have impact in the ED. So let's jump right into them. They want, goal number one, they want to improve the accuracy of patient identification. So apparently if the patient can't even, they can communicate on their own, doesn't matter. You have to have 2 patient identifiers. The good news here is you can have those 2 patient identifiers in the same location. So if it's on the armband, if it's the patient number as well as their name, you're good there. Probably most of us are already doing that. But you have to have 2 identifiers. They want to eliminate transfusion errors. Well, that's a good goal. How are we going to go about it? Well, their plan is they want to have each institution to identify a qualified, quote-unquote, here's another term, transfusionist. Who wants to be the transfusionist? The person who, every shift, which nurse is going to be the one to deliver the blood products? I don't know. That could be a catchy title. Do I get business cards for that? Because if I get business cards, I'm being the transfusionist. You probably don't get paid anymore. And they go one step further. You have to have a backup, the second person who's also knowledgeable of the process. So apparently you can't give blood products unless you've got your transfusionist and the backup subordinate transfusionist person available. So good idea. I'm not sure that this is really going to work in process. All right, goal number 2, improve the effectiveness of communication among caregivers. So this is going to be easy. All right, reading back verbal orders. If verbal orders are given, and what we should do is really just do away with them, you can't have nursing personnel or whoever takes them read them back until they're actually written down. And that includes us. If we're taking information from a medical staff member on the phone and then implementing it as a verbal order from them, we have to go through the same process. So, Dr. So-and-so, you're saying you want the patient admitted to telemetry as an observation patient. Would you verify that with me? Can you imagine having that conversation? I had that conversation in my head, and it was done. It's verified. But you technically can't even have that conversation until you write it on the order sheet. That's what they want. All right. And next step, creating a list of abbreviations not to use. We've been already doing that, so that's good. The not to use abbreviations to make sure that we're not creating medical error. Joint Commission has a great policy on this, and I think all of us have seen it. Timely reporting of critical tests and critical results. Every one of our labs has panic values. They have a process in place to call us when those panic values occur. What the Joint is saying at this point is they want to have those results called directly to a responsible, licensed caregiver. And how they define who that person is the person who can act on those results. They said that you could actually have somebody who is designated as someone else who could take the information, but you have to prove to them that it will not result in a delay in the transmission of that information and a delay in care provided based on that critical result. So if you're going to have a unit clerk or a nurse or somebody else take that information, your process has to verify there's no delay. How we're going to verify that, I'm not sure. All right, managing handoff communications. Anybody worried about patient handoffs? Well, this is a great initiative. It really is. And I think this has been a real problem for us for a long time. Everyone in this room is aware that shift change is a high-risk time for emergency physicians, correct? I mean, it's bad in the emergency department. What we haven't done is really taken a specific approach to address this as a specialty, and we need to do that. And there are several organizations working on this, including ASAP. Actually, the Quality Improvement and Patient Safety section is just drafting a white paper that's going to come out in the next couple of months. And that's going to address some of these issues too. But let me see if you've experienced this. I mean, do you, every time you take over a patient handoff from one of your colleagues, do you go see that patient, do a brief focused exam, and review their data before you act on what your partner said you should do? I think that doesn't happen all the time, but it needs to happen. And are you documenting that in your medical record? Nope. We're saying, you know what, I trust my partner. They're great, and why do I want to go see another patient anyway? If I just have to wait till the potassium comes back and the potassium's okay, then I'll just write the discharge. Well, I will tell you from a risk management standpoint too, whether you see the patient for 5 minutes and the other person sees them for 3 hours, if you are the dispositioning physician or provider, you will take the lion's share of that liability if there's a problem down the road. So even though you've only seen them for 5 minutes, you've got to go in and see them. You've got to go take the time, examine them. And I tell you, every time I've done that, not every time, but I would say a huge majority of the times, I've had a different opinion. I've had a different feeling about things. I've changed something. The patient needed something, and it was important. And I think the reason for that is not that I work with incompetent physicians, is because I'm fresh. I'm at the beginning of my shift. I'm ready to go. Give me everybody I need. There's 6 charts in the rack. I'll take them all and the handoffs. But when you've just finished a night shift, it's 7 o'clock in the morning, you got beat up all night. Are you at your best? Why are we taking that doc's word for it? So handoffs need to be addressed, and we have to be specifically focusing on what areas we need to standardize with this. And it's going to be more work for us, but it's something we need to do. A lot of errors happen with this. A couple more here. How about improve the safety of using medications? They want to make sure that we manage lookalike medications like mag sulfate and morphine sulfate, write them out. They want medications labeled for processes such as for procedural sedation and for RSI, and reducing harm for anticoagulation therapy. They want a nursing policy drafted on how these medications are going to be administered. And the sad thing is, you know when patients come in and their INR is through the roof and they have a bleeding complication? Right now, the surveillance systems that are in place usually end up tagging the ED with that adverse drug event. We're the ones, we didn't prescribe it, we're the ones who are fixing the problem, getting them admitted from the ED. But that's the first point of entry that they can capture it. So when you look at data across the board about where adverse drug events happen, ours are falsely elevated sometimes. All right, hygiene. Reduce the risk of healthcare-associated infections, meeting hand hygiene guidelines. That's going to definitely impact us. We've got to make sure that it happens. Accurately and completely reconcile medications across the continuum of care. Are any of your hospitals in the ED providing a medication list back to the patient at the end of the visit and saying, we've reviewed your medications, here's your new list? And it's a good idea. Most of ours are doing it as well. I don't know if that's going to help or not. At least the patient has a better list. One that worries me a little bit is communicating medications to the next provider. The ED has not been exempted from this. The next provider is defined as a provider that the patient already has a relationship with or already has an appointment with. I don't know how we're going to comply with this, or we even have to, but it's something we're going to have to consider doing. The medication list, which is interesting, most of us in this room sound like we're complying with it, but they haven't exempted the ED, but if you look at the Joint Commission and what they write about this, they're talking about inpatient care. They didn't exempt the ED, but all of the discussion and description they provide is inpatient care. A couple more. Fall reduction program. Yeah, put the side rails up. We don't want anybody falling. Prevent healthcare-associated pressure ulcers. This one's important. This is in that if you should never happen, we will never pay column from CMS as well. If pressure ulcers develop and they didn't have them when they came to the hospital, we're not paying for the care of those pressure sores, those acubiti. What that's resulted in is, unfortunately, resources spent on being diligent, verifying that those didn't exist when they got to the hospital, not preventing them. I know of at least one of our hospitals where a SWAT team descends on the ED when someone's admitted, and they got like digital cameras and they're writing down stuff on the chart, and they're verifying, that there are no ulcers there. Okay, turn them, left side, right side, I don't know why people smile for those pictures, but anyway, they're doing that. Has anyone else noticed that? Has your hospital started to do that out of fear for this? It's coming. It's going to happen to you too. All right, universal protocol. Just be aware that if we're going to do a procedure, we have to make sure that we have pre-procedure verification. We have to have a process in place. Mark the procedure site. If it's obvious, like a laceration, you don't have to mark it. It's right there. That's what I'm going to fix. If it's not a unilateral process, such as an intubation, I think there's only one trachea last time I checked. You don't have to mark the trachea. You can just go ahead and intubate them. But technically speaking, you still have to do the timeout. And the timeout can't be fluff. The person who's going to do the procedure has to be there when they do the timeout. So you're about to do your intubation. Theoretically speaking, you're supposed to sit back for a second. Although there's a little caveat and exemption for emergency procedures, but you've got to make sure that you understand this process, the hospital has it laid out, and you comply with it. And they definitely state any time medications are being used for moderate or deep sedation, you must use this process before any medications are delivered. And they will survey you on that, I can almost guarantee it. The last thing I have to mention is issue 42 came out December 11th from the joint, which is important, and I'm glad they mentioned this. And they noticed that a lot of adverse drug events were taking place due to EMRs and electronics. So I know that a lot of hospitals are pushing us to go toward electronic medical records, but they create in and of themselves their own problems. Just one stat I'll leave you with there is one analysis of 176,409 medication errors, 44,000 of them were computer technology related. Now, if you have computer order entry, physician order entry, have you ever scrolled down, thought you clicked on the right thing and ordered something that you didn't want to give? And hopefully, the nurses pick up on it and they realize that's not the right medicine. I know of at least 3 cases with our physicians where they didn't even know what happened until it came through our peer review process. Hypotensive patient, GI bleed, gets a dose of labetalol, 20 milligrams of labetalol. I know after talking to the doc and reviewing the chart, he did not intend to do that, and looking at where they have to scroll in their system, it jumped or you scrolled to the wrong area. And the nurse gave it. Nothing bad happened as far as we know. But if we're looking at that whole balanced resuscitation thing, hey, that was probably a good thing, right? That's one step further. Drop the blood pressure lower, there'll be less blood loss. All right, that's it for the joint, guys, and I appreciate your time.